Hello, everybody, and welcome back to the latest episode of Pep Talk. With us today, we go north. We go to Canada, where I'm so pleased to have Mitch Brown with us. Mitch is a plastic surgeon of over 25 years. He's a professor in the Department of Surgery at the University of Toronto, and he has a blended practice that spans both academia and private practice. Mitch, so glad to have you with us today.
Sharif, great to see you. Really, it's been a long time. It's nice to be back with you.
It has been a long time, and I know one of your passions is golf. So today in wardrobe, I wore my U.S. Open from 2011, 2012 at Congressional.
I like that.
For you.
Well, we are on shutdown still. I haven't seen a golf course in quite a while, but we're hoping in the next week or so.
Oh, I hope so as well. You're hearing stories; they're opening up, and I'm supposed to go play 9 holes tomorrow afternoon. We'll see how that goes. So legally, I might add. But so glad to have some time with you. Let's just jump right in. I mean, I've talked to a number of doctors here in the States from various specialties, and we kind of know what's happening. We're now starting in the reopening phase gradually, area by area, and various levels of opening, from just seeing patients to full-on surgery of elective procedures. But what's going on up north?
Listen, you know what? It's very much similar to what's happening in the United States. We're neighbors, big shared border, North America. It's much the same. There are some differences. We may have caught the virus, closed borders, looked at travel restrictions, I think maybe a little bit earlier than you did in the United States. And we're 37.5 million people in a massive, geographical space. So that's awfully different than the United States. So we have some flexibility in that regard. And we've got lots of sections of Canada that have had minimal to no impact at all. Mm-hmm. And much like you guys have had in New York and Louisiana and areas like that, we have our core focused areas, the Toronto area, the Montreal area, our big urban centers. But we're in pretty good shape. Things are on the rebound. We're still closed down in many sections of the country. Here where I work in Toronto, we're still on pretty significant lockdown. We're not back into the operating rooms or back into any elective work, but the numbers are coming down, and I think it looks promising for the next couple of weeks.
Are you seeing protests in the streets and people talking about wanting to get back to work, or don't make me wear a mask?
Yeah. We are a little bit, but it's the polite Canadian protest, right? It's 3 people and a bottle of maple syrup out in front of the government offices saying, we should get back to work. I think there's been a lot of social acceptance here. There's been a tremendous cooperation in most regions. Much as what I see in most of the places in the United States. And then, patience is wearing thin. People are getting ready to get back to work. I mean, I look at the numbers in our province of Ontario, which is the biggest province population-wise in Canada. It's hard to know exactly what the prevalence is, but it looks like the prevalence of positive COVID people is somewhere in the range of 0.4 or 0.5%. And when you're dealing with numbers in that range, it's hard for the 99.5% to really be feeling that they need to be under lockdown. So I think patients are wearing a bit thin, and I think governments are starting to accept that and looking at ways to accelerate a reintroduction into some sort of normal work cycle.
Well, let's look at your field of expertise, plastic surgery. And I'm just going to assume that, the what happens in Canada is pretty similar in terms of patient acceptance and desire for elective procedures. What do you see in terms of the rebound and reopening? Are you getting any feedback from patients now about, they want to come back in and have things done?
Listen, really from the beginning, the phones didn't stop with patients who wanted to know, when will you be open? When can I get in? I've scheduled, this is the right time for me. So I think the appetite for surgery, the appetite for non-surgical procedures, injections, fillers, things like that, is really there. People are respectful. They realize there needs to be, physical distancing. There needs to be mask wearing. There needs to be a stay-at-home policy until things are safe, until, personal protective equipment is ensured. We had I think, a bit more of a concern about access to PPE than maybe you did in the United States, but we feel like it's under a pretty good situation right now. So I think patients are ready to get right back at it. I know my fellow colleagues are ready to get right back at it. Our staffs are ready and prepared. We just need government policies to say it's okay to sort of open up again. And I think that's coming quite soon.
It's really good to hear. And just kind of Canadian society in general, do you feel that same kind of, chomping at the bit that you described for elective procedures? People want to get out and do things?
Well, yes, everybody wants to get out and do things. But listen, it's a pretty socially obedient society that we have up here. And I saw a poll that came out just the other day that said about 70 to 75% of Canadians are comfortable with the pace of reopening that they're seeing in the country right now. Mm-hmm. So I think people are kind of resigned to the fact, listen, we're in it now. It's been 6 weeks. We're making good, positive progress. Numbers are coming down. Let's accept that a reopening is right. We need to have that happen now, and let's do it slow, steady, and right so we don't have to go backwards. I think that's where we're at. Those of us that are ready to reoperate, at the hospitals where we're working, we're shut down totally. We have been for quite some time. And there's such a backlog of patients waiting for surgery that I don't know how we're going to clear that. So we need to get back into the operating rooms, at least in the academic centers and in the hospitals. And we're doing our breast cancer surgery work and reconstruction right now, but it's almost on a case-by-case basis. And so I think a reopening is necessary. We're almost on the precipice of that happening, I think.
Given that you have nationalized health, right, something which is being fiercely debated for decades south of the border here, what's that impact been like then to hospitals and clinics? And just by comparison, our local hospital here in town is in financial difficulty because they prepared for a large rush of COVID-related cases coming to the hospital, sent up a big tent outside, and guess what? We've had very few cases. It's just been good here, like in terms of we haven't had huge outbreaks as of yet.
Yeah.
So they're in financial difficulty. What about where you live?
It's a different system. It's really a different philosophy. In the United States, my understanding is there's many hospitals that need activity and need things happening in order to survive because they make money off the work that they do.
Correct.
The philosophical difference in Canada is hospitals are funded by a single payer, and they're usually underfunded for what they really need and want to do. So when they're not working, it's financially beneficial. It costs them money to work. Whereas in the United States, they benefit from work. So it's a bit of a different philosophy. Now, that's not to say people are happy that we're not able to work, but hospitals certainly are not suffering because we're not able to function in our normal way. The people that are suffering, of course, are the people that need to work there and the patients who require the care. So I think from a financial point of view, it's not really such a significant problem. And really the other thing to recognize in our system, which I think does function very well, we're accustomed to waiting. Wait lists are pretty typical in our system, and people are used to going into an emergency department and waiting for hours to be seen. And people are used to coming and seeing a surgeon and be told, listen, it may be 6 months, 9 months, a year before you get your treatment done. So I think we're preconditioned a little bit to just not get immediate access to care, as in contrast to what I think a typical American might feel.
Well, it brings up 2 points. The first is, I'm fascinated by what your opinion and view must be looking south at us and all the debates about whether it was Obamacare, Trump getting rid of Obamacare, private, socializing medicine, one payer. What's your view on what we should be doing here?
Oh gosh, now how long did you want this pep talk to go for?
Be short.
It's a long conversation. I don't have the answers to all of that. I can say that there's some great things about our healthcare system in Canada. And I think there's some fantastic things about the healthcare system in the United States. And if we could just find a way to blend those models, we might have the ideal system. What do I know for sure? I know for sure that if you're living in a first world country, if you're a citizen in a first world country, you really ought to have the right to good, clear, safe, affordable access to healthcare as a right of citizenship. I truly believe that. I think that's just humane and that's appropriate. So I love that about the Canadian system, is if you're a Canadian, you know that you have access to healthcare. In the United States, you can have access to healthcare that's at a much higher level than what we're able to access in Canada because you can pay for that. Well, we can't do that in Canada. So I'd like to see if we could find a way to blend a model, I really think it would work. Find a basic access of care that's high quality for absolutely every citizen and allow people to access a higher level of care by their choice, just as they can choose higher level education, higher level housing, higher level nutrition, whatever you are able to choose. But that's on the basis or on the foundation of a good quality level healthcare that's available to everybody. To me, that would make sense.
Yeah, you watch out. You might get recruited to come down here and help us. Just warning you now. The second topic from what you just said was about wait times. And you were. I was so privileged to have you as one of the very first readers of the book, and we included your quotation right inside on page 1. And thank you for that, Mitch. I really appreciate that. I just want to see if you had any thoughts about how the book has impacted your thinking about your practice.
Well, first of all, the book's a great accomplishment, and that was a huge thing to do. And I think the concept of thinking about how we work within the medical system, how you run your practice, how you try to be thoughtful at everything that you do, how you try to blend science, art, and business and administration all into the success of a practice is difficult because we all have our own strengths and weaknesses, and we all migrate to the things that we're better at and sort of shun away from the things that we struggle with. So I think when you see a book like that that's laid out where almost chapter by chapter, there's a lesson there for you from a different concept of what works within the total, gestalt or construct of your practice, it can be very helpful. So you can pick it up and just sort of say, listen, you know what, I need to review a little bit about managing my staff and how to deal with contracts, or, what's the best way to deal with a problem patient. And there's some pearls and messages, I think, all throughout that book. So, it was a pleasure for me to be able to comment on it because I think it was, very beneficial and had a lot of positive messages in it.
Well, thank you. And one of them, and you really touch on it, wait times. We're in 2020. No one wants to wait for anything. I mean, except maybe if you're Canadian, right? You said Canadians will wait. But I even believe that as customers, if they're coming into your private practice, they don't want to be waiting. They want to see you or the specialist right away.
Well, that's true. And that's the difference. So, that's one of the unique aspects of plastic surgery in Canada is that, our practices will be, are really quite different, whether we're dealing with publicly funded concepts. So, I work in reconstructive breast surgery, and that's all considered a medically necessary procedure, and it's done through the public healthcare system. And we try to provide access as quickly as we can, but we're restrained by the resources that are provided to us within the hospital. And so we work as quickly as we can, but there's a wait time. And if you have a patient that wants to come and have private surgical care for something that's not considered medically necessary, we can treat them in our own private facilities, and we run the show there. So we can keep our wait times to where we want them to be. And you want to work longer, you work longer. You want to work on the weekend, you work on the weekend. You do what you can to satisfy your patient needs. So it really, it shows you what's uniquely different between those two aspects of care. We need to, if we could have some improved funding within our public system, then that would help to bring down those wait times. We're an aging population. There's more procedures that we can do. There's more technology that's available. There's more expensive technology that's available. So, new sources of funding, I think, are going to be critical.
No doubt. Well, I'm an advocate, as you know, in that one insight on blowing up the waiting room altogether. And whether you can reduce wait times or completely eliminate the concept of wait is as much a manufacturing concept as it is one for a medical practice. And we'll be bringing some services to practices to help them, some tools so they can begin to measure and implement change to shrink that time down, which we know will lead to increased patient satisfaction. So, Mitch, any final words of wisdom that you want to share with people who are listening? It is called Pep Talk, and we give you the last word.
I appreciate that. I'm not sure they're words of wisdom, but if the last 6 weeks has done anything for me, it's been an opportunity to sort of sit back, reflect, look at where my professional career has been, where my life is, what are priorities and what's important. I hope we all don't run out of the other end of this COVID slowdown or crisis and just jump right back into our normal lives. I'm certainly going to try not to do that myself. I think it's going to be important to realign our important priorities, realize that slowing down a little bit may not be the worst thing in the world, appreciate the things you mentioned about wait times. Maybe waiting a little bit isn't the worst thing in the world. Maybe being at a stoplight and somebody's a little slow to go through it, just take a deep breath and not let it bug you so much. And so I'm going to try my best to adopt that philosophy coming out of all of this and enjoy life a little more and not be in such of a rush in the rat race. And we'll see how that goes. That may last a week, but I hope it lasts a long time.
Well, we heard it here from you first. Thank you, Mitch Brown. Thank you, audience, for listening. Until next time, I'm Sharif Madavi. Stay safe,